Welcome everybody and good afternoon. I'm Mike Fraser, the Chief Executive Officer of ASTHO, the Association of State and Territorial Health Officials, and it's really a pleasure to welcome you to our COVID-19 TechXpo. This is our opening plenary, Public Health, COVID-19 and Technology Innovation, and you've got two great speakers to hear from this afternoon, Dr. Nirav Shah, who's our ASTHO President, and Dr. Karen DeSalvo, who'll be delivering our keynote. Karen is with Google Health. Lots to talk about and lots to share. But as we get started, I'd like you to join me in thanking our sponsors of the event. You can see on the next slide here our premier sponsors, AM Trace, Checks Out, Eagle Force Health, and Zebra Technologies. And we also want to recognize our gold level sponsors, Healthy Together, Healthvana, SunQuest, and Backstrack. And please be sure to visit our sponsor booths in the exhibit hall and join them at the end of the day for a networking conversation, several different topical sessions you can join and learn more about what innovative approaches they can offer to your COVID-19 response efforts. Well, it's a pleasure to be with you today. I know many of you may be getting to know ASTHO for the first time. And on the next slide, you'll see our ASTHO vision and mission. ASTHO is the national association based in the Washington area with a regional office in Atlanta. And we are dedicated to state and territorial health agencies advancing health equity and optimal health for all. And everything we do is supportive of assuring the conditions for people to live healthy lives. Our mission is to support, equip, and advocate for state and territorial health officials in their work of advancing the public's health and well-being. And as you all know, the challenges of COVID-19 have really required a great deal of effort from our nation's public health agencies. And you'll hear from several of our alumni during this afternoon session, as well as from our ASTHO president in just a minute. On the next slide, you'll see just some of the dark cloud, the dark word cloud of COVID. You know, lots of things we've learned, lots of mistakes and lots of challenges. But there are bright spots. And on the next slide, one of the biggest bright spots from my perspective is the opportunity for innovation and ways that we can use this moment to improve our public health infrastructure and expand our public health partnerships. And just some of those innovations include things like contact tracing and exposure notification, case management systems, healthcare and facility reporting to public health agencies, vaccine tracking, scheduling, credentialing, as well as opportunities for community linkages, using technology to counter fear and misinformation, and leveraging the power of technology to share important public health messages. What we're hoping to begin a conversation about today on the next slide is our vision, a shared vision of a well-functioning, integrated clinical and community health information system that informs real-time decision-making. And many of the sessions today will talk about technology solutions that are supportive of that, of a well-functioning, integrated clinic and community health information system that informs real-time decision-making. And that's a technological challenge, but also a policy challenge. And so you'll hear today about the need to set standards and develop recommendations and reach consensus as a community of practitioners. You'll hear today about sustainable funding. You'll hear today about key principles related to interoperability and integration of systems. You'll hear about the importance of connecting clinic and communities across the country and around the world, and a lot of attention to privacy and how data are shared and who's allowed to see what. And as we move forward, we're hoping that from our ASTHO point of view, we're hoping that future investments in technology will really lean towards enterprise-wide solutions that are neither program nor pathogen specific, which has been our history in public health information systems to date. We have a huge opportunity in front of us. And on the next slide, again, this is a detailed slide, but you can just see some of the numbers of the dollar investment in public health that were the result of COVID. And many of these were recently just appropriated through the American Rescue Plan Act. Some of these resources came earlier last year as part of the emergency appropriations. But public health is now in a great position to be well-resourced, to leverage new dollars to build systems that work. On the next slide, you'll see even some of the more specific investments around information technology and a major priority of our public health partners, as well as ASTHO, which is data modernization and bringing our public health surveillance and information systems well into the 21st century. And you can see again, just some of the dollars and investments in many aspects of the public health system, all of which have a touch to information technology. On the next slide, I just wanted to share with you a report that has really informed our thinking at ASTHO and led the way with our partners in thinking about how to modernize our public health surveillance and data exchange systems. This is a report called Driving Public Health in the Fast Lane, the Urgent Need for a 21st Century Data Superhighway. This was released in September 2019, and it's just as relevant now as it was those in 2019. You can find that on www.cste.org, which is our Council of State and Territorial Epidemiologists website. They're our partners in the work of epidemiology and surveillance. And on the next slide, I just wanted to conclude by sharing just 3 of the barriers that are highlighted in that report, about which we'll be spending some time thinking this afternoon in many of the sessions. But progress has been made to improve public health surveillance, but that progress to date has often been very limited in scope and often focused on just one component of the system, which is why we're stressing the need for enterprise-wide solutions. Another roadblock has been building disease-specific surveillance infrastructure, which creates redundancies and inefficiencies. And it would be a terrible mistake to make to create the best surveillance system for COVID in the world while leaving partners in other program areas or other pathogen-specific systems behind. And finally, the report also suggests that technology's potential can only be realized if public health professionals are equipped to harness it. And we have a tremendous need for building the informatics and IT and technology workforce within health agencies and within government more broadly, and that's a big issue for us. Well, to share some more comments and to introduce you to our ASTHO president, it's now my pleasure to turn over to Dr. Nirav Shah. Dr. Shah is the director of the Maine Center for Disease Control and leads the activities in that state specific to public health COVID response. Prior to that, he served as the state health official for Illinois. So with that, Dr. Shah, I'll turn it over to you. Thanks for joining us.
Well, it's my pleasure, Mike, and good afternoon, everybody. I am so delighted to be able to join everybody. I'd like to extend my thanks as well for everyone who's tuned in, as well as to echo Mike's thanks to our corporate sponsors for helping make this event a reality. I would also be remiss if I didn't take a moment to thank the team at ASTHO for bringing this entire event to fruition. To be able to plan something of this scale and scope with speed during the midst of a pandemic is a feat unto itself, and I'd like to take a second to thank them, as well as to thank my good friend, Dr. Karen DeSalvo. We are so delighted that Dr. DeSalvo has been able to join us today. I'd like to take a moment or two to frame some of the issues that Mike noted and actualize them or localize them to the manner in which state health departments across the country right now are seeing them and how we are having to react to them. As Mike noted, we are in an interesting place in public health. For one of the first times in over a generation, public health funding has been brought into sharp focus. And as Mike noted on his slides, funding and the money to make some of the ideas that we have come true is something that we haven't had the opportunity to harness in quite some time, but it's now an opportunity in front of us. And so we have this opportunity to not just leapfrog beyond COVID, but also think about what public health data and informatics should look like well beyond and into the next generation. Doing so will require us to reckon with and grapple not just from the mistakes of pre-COVID era, but from the challenges we faced with COVID specifically. We have most definitely identified gaps in the public health architecture around data. We now have an opportunity to fix them, and we should do so with an eye not toward the next couple of years or the next pandemic, but for the next generation or two, if not longer. One of the challenges that every single public health department has faced has just been moving away from a paper-based system. I can say of my own agency and perhaps others that state health departments right now are pretty much single-handedly keeping the fax industry alive. Simply by moving our systems away from purely being paper-based to electronic-based, that in and of itself would significantly improve and enhance our ability to do the analytic work that we need to do. We are also behind as a group when it comes to using modern and cutting-edge analytic tools. This is why I'm so delighted to be here with so many members from the private sector. We in public health have much to learn from our colleagues in the private sector around how we can and must modernize. Private industry can modernize and analyze data quickly and adeptly, and we need to learn from that so that we can make our work relevant. Just one example of that is the way in which the private sector makes regular use of predictive analytics, but in a way that in state health departments, we still lag. I think all of us in public health know that when it comes to public health issues, what we can predict, we can prevent. But not being able to make solid data-based predictions about where something may go hampers our ability to do real prevention. Another area or few that are specific to COVID are around problems that we faced just throughout our management of the pandemic. Some of this started early on with things like the need to have robust, thoughtful, and flexible systems around things like contact tracing and case investigation. Again, speaking only of my own department, all too much of that work was paper-based, not electronic. Even when we did move to an electronic system, we needed to catch up and modernize in other areas of the agency to avoid creating that silo that Mike noted. More recently, with the rollout of vaccinations, scheduling has been a significant challenge. Scheduling is something that the private sector knows to do quite well, but we in government are not used to that. And so many state agencies had to look to private sector solutions in a hurry. But that, of course, raises the challenges that many private state health departments have around things like contracting and procurement. Once we've gotten scheduling in place, however, we need to keep those things nimble. We also need to keep them open to all. One of the questions that I've gotten perhaps more than any other in connection with scheduling is, hey, why can't you just use an off-the-shelf solution? I don't understand why company X can have a scheduling platform that's open and available and you at the state level can't do that. There are, of course, differences between the way that state health departments operate and private sector companies. We have to be open to all. We have to have certain access requirements. Making those things clear to others is one step toward getting buy-in from the public around the work we do. It just so happens that we are having this conversation at the intersection of technology and public health during a week when the national conversation has started turning toward the future. For example, around things like vaccination certification. How should we think about that, and how should we integrate modern technologies into what is a relatively traditional technology workplace? Things like blockchain technologies are standard fare in much of the private sector, but how do we make them a feature of the work that state health departments do as well? Now, these problems facing us are not computer science problems. They are political science problems as much as anything else. We have an opportunity to take the technology that exists elsewhere in other sectors and bring it into state health departments, utilize it, and use that as a way to modernize the work that we do to keep people safe and healthy around the country. There is perhaps no one else in the country better suited to discuss that with us than our keynote speaker today. I am so delighted to be able to introduce Dr. Karen DeSalvo, who I am so pleased is able to join us. Dr. DeSalvo is the Chief Health Officer at Google Health. She is a nationally recognized public policy leader who has for quite some time now been working at the intersection of medicine, public health, and information technology. She previously served as the Acting Assistant Secretary for Health and the Director and the National Coordinator for Health Information Technology at USDHHS under President Obama. It was during that time that she launched Public Health 3.0, a vision for 21st century public health. But just as well as Dr. DeSalvo knows the policy world of DC, she knows the trenches of public health. Dr. DeSalvo was previously the commissioner of the New Orleans Health Department, and following Hurricane Katrina, was an instrumental leader in the efforts to re-engineer healthcare across the state of Louisiana. I could not be more pleased to have her with us today to kick off our discussion. Dr. DeSalvo, thank you so much for joining us. I'm delighted to turn things over to you.
Oh, wonderful. Thank you, Nirav. It's so great to be here virtually with everyone. And as I shared with you before we started live, I'm so proud of and impressed by your leadership. And I just want to publicly acknowledge and thank you and tell you how wonderful it is every time I hear your calm, reassuring voice on NPR that you're representing the public health enterprise so well. So thank you, and thank you to everyone else out there who have been heroes these last not only 15 months, but all the years leading into it. I think we can put up the slides, and thank you so much. What I want to walk through today is sort of an arc of first, how Google's actually a public health company. Secondly, is how that ties back into Public Health 3.0, and then thirdly, some thinking about where we all go from here as we want to move into this post-pandemic era, and what kinds of priorities we should set for ourselves. Next slide. We say a lot at Google that the purpose of health is rooted in our DNA, and we have this very famous founder's letter written back in 2004 where they said our goal is to develop services that significantly improve the lives of as many as possible. And next slide, I came to Google to join a unit called Google Health, whose mission basically is to organize the world's health information and make it universally accessible and useful, particularly for people and for those they trust. That was in December of 2019, but then things started to change in everybody's lives, including ours at Google. Next slide. We do actually get a Noogler hat when we join Google. This is my beanie propeller hat, and I was only a couple of months into the job when the COVID pandemic began to play out globally. We have, as many of you are probably aware, offices all across the world, so we had already been experiencing in parts of Asia closures of offices and challenges for our employees and their families there. Certainly the bulk of our employees are here in the US, so sometime around February, things got very intense for us with respect to how as a company we would respond to protect employee health and safety, and how that would align with how we wanted to help community. We were one of the first companies to go to work from home. We wanted to do that because we could, and we felt that if the less we were in the office space, and more importantly, going to and from the office on public transit, or taking up any opportunity where we might be a link in the chain of transmission, that we did not want to do that. We wanted to be a part of social distancing and what soon became the shelter-in-place expectations. Next slide. But we also knew that we're a consumer company first and foremost, and millions of people come to us every day seeking information, including about their health. And so job one was right information, right time to people so they could protect themselves and their families and do their part in community. Now, we don't want to make up our own authoritative information, but we certainly want to do everything we can to lift up authoritative information from authoritative sources, particularly in this case, public health. So we started with our SOS alert, which linked people to places like the CDC and the World Health Organization, just as a top banner on the search bar. That quickly expanded into us building more of a custom search experience when people searched on COVID or COVID-related items, as well as ways that we can build out knowledge panels so that as people search on COVID and begin to want to click through information like symptoms or how to get prevention or what are the treatments, as the pandemic evolved, we're able to grab information from authoritative sources in the US, particularly the CDC initially, but then begin to push that down so that when someone's in your state or in your locality, you can find that information about the Missouri Health Department or Louisiana Health Department, that is more localized and informational for people on the front lines. The other surfaces where we can do this are Maps and YouTube. YouTube in particular is a really flexible way for us to not only get the right message out, but do that via the right messengers, because we have influencers who are very willing to help lift up good information for consumers in the US and around the world about the pandemic. Next slide. We also have ways that we can push forward information from health departments, particularly through our ads grants. Something I wasn't really familiar with till I joined Google, but it's a way that when you search again on a topic like COVID vaccines, we can make sure that for the health authority, there's information showing right at the top. That's a blue link that people can click on and help them navigate to, again, the CDC, or it's very often states, or we just did a partnership with New York City. It's a way to really get your message out as people are looking for information, another avenue. And we're doing a lot of this work right now in vaccines and vaccination sites, both on search and Maps and YouTube, really trying to do our part to see that everybody gets equitably vaccinated, and that we're bringing forward the best data and information. And then on the counterweight of this is always our attention to taking down misinformation, whether that's purely harmful, like calling COVID a hoax, where we have clear policies that we can pull that out of the ecosystem, and or finding ways that we can make sure that we're branding or flagging things that might be sort of right on the edge. That's both through machine learning, but also through actual people who work on my team and people around the world that are clinical experts that speak dozens of languages, that we're constantly looking for opportunities to take down harmful misinformation. I mean, on YouTube, in the pandemic, we pulled down about 200,000 videos that were found to be harmful or to be egregious misinformation. Next slide. I think the place where I'm beginning to be more and more proud is because it's expected that we'll provide consumer information, but what we've really been striving to do is forge partnerships with public health. And there are a few ways I'm just going to mention that we've been doing that. One of them is early on developing the community mobility reports. This is a way that consumers and public health can look to see how people are responding to shelter-in-place orders, and trying to think through where the riskier areas that they might need to add some other, you might need to add other layers of protection, like in parks or in transportation. This data now is scrapable and has been used by researchers in thousands of publications. It's part of the CDC's publication of data they have on their website, as well as the World Health Organization and Our World in Data. So this is an opportunity for us to take anonymized, privacy-protected data, push it out not only as a visual report, but also to have the data behind it that can be scraped and be reused for additional purposes. Next slide. Thematically, this similar idea with the search trends data, you can always get search trends, but we haven't had a bucket that's been about health. We now have more than 400 signs and symptoms that we've line by line vetted. This grew out of the work, meaning line by line, these are things that we think might be related to COVID. This grew out of the efforts around anosmia, where people saw that searches around anosmia was a prelude to there being an outbreak of COVID in community, and caused us to want to make sure that we were doing everything we can, again, with this anonymized data to make it available for public health as well as for public health researchers to do better jobs at predicting. It's actually 3 years of rolling data. And I have to say, for me as a local health officer, this would have been my favorite, because I can say in my jurisdiction, in my county, what are people thinking about in health, not just around COVID, but in some of the related areas like mental health or even in chronic disease. Next slide. We've also got some more sophisticated tools where we've taken anonymized data sets and partnered with academia to do things like create maps that can help track variants and take some of the, again, data that might be inside of Google, but also partner with others to see that we can make that data sing, leveraging artificial intelligence. Next slide. And Mike mentioned this in the beginning. I think the most partnered-oriented project that we've had is around digital contact tracing, where almost a year ago, we were asked if we could help with contact tracing using location status or GPS. And for privacy reasons, Google and Apple both were not a fan of that. They wanted to find a pathway where we could do something that was privacy protecting for consumers, but also informative for public health. and had, in this case, the added benefit, because we use Bluetooth, low energy, doesn't drain batteries. And by creating an interoperable system, we're able to leverage both the people who have an Apple phone and people who have Android, which really broadens the equity opportunities. Create basically an API that's available only to public health departments. Many of you out there, about half the states in the country, a little more than that, about 24, have built an app on top of the API. Some of you are using now this appless model that was developed after getting feedback from you all that would be useful. And we've been able to provide this tool for more than half the US population. And now working with MITRE and NIH, many of you are going to have this privacy server that's going to be able to understand the impact of this tool. What we know, for example, though, is in the UK that it probably avoided 600,000 infections. So we're getting some data from Europe, which was earlier in and has been working on the analytics to understand the impact, not a replacement at all for the important human work and other components of contact tracing, but another tool in the toolbox that we felt that we were able to create and support. It's also got this hidden opportunity where we've been able to build bridges with public health, and I'll get back to that in a little bit. Next slide. For those of you who are interested in some of the data I talked about, I do want to just throw up this slide, which has our GitHub site, which is the data science for public health. It's a place where you can not only watch some videos about what we have available, but find some of these other data resources if you're interested in using them, not only for your everyday practice, but also for public health research. And we look forward to hearing from you how we can continue to make these more available and helpful for you in the work that you need to do every day. Next slide. So what does this have to do with Public Health 3.0? I came to Google thinking that it was an opportunity to bridge medicine, public health, and healthcare. It certainly has been. COVID's been an accelerant to our opportunities to partner with public health and with medicine, and to think about how we can be, we as a technology company can be a part of a broader solution to do our part to improve the public's health. And I came to Google with this foundational understanding of how public health as a sector has evolved longitudinally, often based upon the changing epidemiology. I mean, early when public health was created in the US, it was really much more about communicable disease, about waterborne or foodborne illness, and ways that we needed to protect people with vaccinations or other tools in the toolbox. But over the course of time, chronic disease became the more predominant epidemiology. And when we crafted the Public Health 3.0 vision, social determinants of health or deaths of despair were the leading cause of morbidity and mortality, and of the decline in life expectancy, and of significant disparities in health outcomes in the US. This was now just about 4 years ago. And it certainly was driving public health more and more to want to do partnerships. And that meant that they needed to have a way to be a part of the overall community infrastructure that was more than just managing the programs and the money that was in front of them, but actually being a part of a broader ecosystem. Next slide. Public Health 3.0 has these 5 areas: leadership and workforce, this kind of chief health strategist model. The second is essential infrastructure, thinking about how there's particularly accountability through accreditation. The third was about strategic partnerships with the business sector, with technology, with others in the community. And then the fourth area about data analytics and metrics. And the final area was about flexible and sustainable funding. These were thematically what we heard in listening sessions as we went across the country. They reflected my own experience as a local public health leader. And in the report, we talked about what we saw in the field that was working, and how in these 5 areas we should make progress in the country to help move to a 21st century model. I think, again, thinking a lot about the social determinants as being a driving factor in morbidity and mortality. But certainly what we've learned in COVID is that you need all of these elements in a communicable disease pandemic as well. Next slide. Because we've seen that these pre-pandemic challenges that all of us have been facing, this shortage of workforce and the aging workforce that we have in public health, that's telling us in surveys that they might be leaving. This notion that not everyone across the country has foundational capabilities to protect them, meaning the public, that there are gaps in what we can fill on the front lines based upon funding and other resourcing that we don't have available at our disposal, that the purview of public health is broadening, not only through social determinants, but as we've seen, the need to really have a rapid cycle data infrastructure so that we can meet the needs of something like a global pandemic. And finally, came into this pandemic really shorthanded financially, but also with very stiff funding. It was hard to flex and allow us to really lean into the work for our communities and our population. Next slide. Interestingly, it's the data and tech stuff that has gotten captured a lot of the imagination for the country about the challenges for public health, and probably because people feel it so intently. They saw that public health and the CDC struggled to do surveillance, and Johns Hopkins had to step in and do some of that public reporting of data. We saw that the systems between the laboratory capability to results reporting weren't always interoperable. And in some cases, it was just because new testing came online, but in other cases, it was because of overwhelming challenges of the infrastructure as well as a lack of interoperability. And there was also a recognition that we were going to need to do a better job of tracking and addressing equity. And our data systems weren't really set up to really help us know who the most vulnerable were and how they were being affected by this pandemic. Next slide. And so one of the things I want to point to about our go forward as we've sort of run up into this pandemic with challenges, when I say we, I mean public health and all of us that care about and want to support public health, thinking about these broad areas of gap, but also areas where we have a clear opportunity and a need to make sure we are strengthened for everyday work as well as for disaster. The National Academy of Medicine asked for there to be a report on reimagining public health for the post-pandemic era. And I had the opportunity to co-lead that with Bob Hughes at the Missouri Foundation. And you see the other co-authors on this report, which will be out next week on this slide, including Mike Fraser and some of your former and current members. So this is a group that knows public health well, a group that deeply cares about and respects. However, when heroically has leaned in with limited resourcing, and we want to find a way to build upon the strengths, but also identify gaps and make recommendations on where to fill them. Next slide. I just want to give you the high level 6 areas, and then I want to dig in a little bit to the modernizing data and IT capabilities piece before we close out. Just to say that to start, clear recognition that resourcing matters, especially financial resourcing. And it's not just about pouring more money into the system, but ensuring that that funding is taking care of the foundational capabilities so that there's a steadiness to the everyday work that we do, and we can build resiliency into the system, have a more stable workforce, and make sure that we're ready to take advantage of new challenges that our communities might face and not wait for that boom and bust cycle of funding. The second area is about affirming the mandate for public health. We saw so many challenges with public health officials across the country being questioned, leaving office, being pushed out of office, because there wasn't clarity for the public about what is the role and responsibility, including the statutory underpinning for the work that we have to do. So some opportunity to make sure that we've got clarity and some harmonization across jurisdictions. The third area was about promoting structural alignment, and this is the sticky area often for public health, but it seems clear that where we have overlapping jurisdictions, there can be challenges about how who's in charge in the middle of a disaster. It's also clear that there are opportunities for shared services. Not only during the pandemic, we've learned this, but we've seen successful models in places like Washington State, where they've already been learning to take advantage of. They don't all need all the same replicable services and capabilities, but in fact, especially when they're adjacent, they can share some of those responsibilities. The fourth area was about investing in leadership and workforce development. This is so important to me. I don't even know how much to emphasize it, but what I wouldn't want us to do is just to put more money in the system or to buy more IT or harmonize our data standards without recognizing that there are actual people, humans, who have to conceptualize, have to do the strategic work, have to communicate what we learn with the public and build that trust every day. We have really important work to do with our workforce, both incumbent and the pipeline. The Last area I'm going to skip to is supporting partnerships and community engagement, because it relates to trust. Public health is on the front lines, embedded in the ground every day. It's what you do so well. You have those trusted relationships, especially with the most vulnerable. And I want to make sure that, and this report does as well, that we're talking about how important those community partnerships are, and how important it is to have partnerships with other sectors. We often go straight to medicine, but technology and the business sector are going to be critically important going forward, so that everyone's aligned to think about how we can work together to improve the public's health. And I'll just end on the modernizing data and IT capabilities, if you can go to the next slide. Because our recommendations in this space, I think, will resonate with what all of you are thinking about every day. They map against what CSTE and others are thinking about in terms of their roadmap, and what I understand the data modernization efforts to be for the CDC and the Office of National Coordinator. I think there's this beautiful convergence about thinking of modernizing the digital infrastructure for public health, doing that in a way that brings a 21st century infrastructure for public health, not only at the local and state and federal levels, but also allows it to establish standards that will make it interoperable, not only with itself, but that it can be interoperable with key partners like the healthcare sector. This gives us the opportunity to modernize surveillance approaches, that we can include novel signals from data sources, whether that's from social media or from electronic health records, as well as from crowdsourcing. There's, again, pre-pandemic examples like Macroscope, but also pandemic examples where we have learned that more timely data sometimes can give us clues like search symptoms trends and the anosmia example I gave, that help us then go more deeply to understand how to get ahead of challenges the public's going to face. And finally, the work that I think will be deep and important for ONC and CDC, as well as for the private sector, is to set national standards to make sure that we can not only have harmonized data, but we can do this in a way that we're routinely disaggregating by race and ethnicity and other socio-demographic characteristics to ensure that we're taking care of the most vulnerable and applying those resources to do right by them. Next slide. Won't go too deeply into this, but I just want to make sure everybody in this audience is aware of how much ASTHO has been thinking about and writing about this. And I love this paper on the need for public health data modernization as a priority, and appreciated the call out about the exposure notification work. Because next slide, I think what we all have to consider coming out of this pandemic is not just the work that public health needs to do to be strengthened, but the commitment that we all need to have to bridging the private and the sector and public health. This diagram reflects some of the parties that were involved in the exposure notification work. These competitors in Silicon Valley, Google, Apple, Microsoft, coming together in partnership with public health, whether that was the CDC or APHL or the local public health agencies, to really see that we could learn each other's language, understand where we had opportunities to strengthen and build bridges. I can tell you, for Google's part, we've learned so much about public health, and there's a set of relationships there that we'd like to continue following the transactional work that has happened with exposure notification. Next slide. So as we go forward, I think we have to focus on making sure that we are, yes, retooling health departments by, in particular, adequately funding the public health infrastructure, but considering also how we strengthen workforce and the other key foundational supports that will be necessary to do the work every day. Second, that we are tending to being ready for public health emergencies. That may not be a communicable disease emergency. I suspect you all are already seeing substance use disorder as an emergency that's coming back for us to have to address, and this will be all very helped by modernizing our technology systems in ways that make them interoperable within the sector and across sectors. And finally, as we reimagine public health, I hope that we will all remember the adage that public health is what we do together as a society to create the conditions in which everyone can be healthy. We have to break down these silos and continue these partnerships so that we can all bring the best that we have to the table and make, as we say in Louisiana, a wonderful gumbo. With that, I will close and just say thank you all for your work every day, and look forward to, if I have time for a question or two, happy to do that.
Thank you so much, Karen. That was great. I love the road forward. Those are three really compelling points. And again, thanks so much for sharing those thoughts with us. We appreciate it. And we've got some great questions from our participants. I'll just try to get through a few since we are close to time. One is from our alumni and friend, John Weisman. And he asks or says, thanks, Karen, for your leadership and support. What is your assessment of the effectiveness of exposure notification electronic tools here in the US? What lessons should we take away for future use?
Well, we don't have as much data in the US context about the effectiveness as we do in places like I mentioned the UK, but also Switzerland, Ireland, the Europeans. Let's see, and the reason for that, just to be clear, is Google and Apple don't have any of the data. It all is in the public health infrastructure. So we've had to work in partnership with public health, as well as with NIH and MITRE, I mentioned, to be able to stand up a privacy analytics server that will allow for some of the analytics to happen here as other countries around the world have done. But what we really learned, I think, is that I was just on a call. I was just on a National Academy of Medicine. I'm going to use the example that somebody used there, which is great, and that is when big tech and public health come together in a room, it's like a middle school dance. Everyone kind of stands on the other side of the room and no one's quite sure what to say or what to do with each other. And even though we had bridging folks like myself and Karen Smith, who's a part of my team, there was still a lot of language we didn't understand from each other. And I think so we just had a lot of, I think the lesson I learned is that the same thing we learn every time we try to build a new partnership. You have to come in with humility, with openness, with an acceptance that when you say API, someone may not understand the difference between that and an app. Or when we talk about privacy, everyone's got a different sensibility about that. So we were very rapidly building partnerships in the middle of a crisis, but I don't want to lose that because now we have those bonds amongst a number of these tech companies, as well as with public health leadership and the local level. So let's build on that to do more into the future. I think the other thing we learned, just to say it quickly, is that technology is a tool in the toolbox, but the trust is a last mile effort. And that's why I can't say enough how important it is that these tools are in the hands of public health, not in the hands of technology companies, because you are the ones that have the local relationships that really, at the end of the day, will cause people to want to participate in improving the public's health.
Great, thank you. We have a lot of great feedback on your talk, so just great feedback real time here. And this question asks, thanks for a terrific presentation. You mentioned the foundational importance of equity and social determinants of health in the COVID response. And obviously that's been a theme of your work, life's work in public health. What do you see as tangible approaches to ensure equity in digital health? In particular, I'm thinking about vaccine passports and AI as a medical device.
Oh, that's a whole talk. So yeah. I'll say, look, it's top of mind for us that, and we had an acceleration of our appreciation of how we as a company need to have an equity lens in all of our work, including AI. And maybe, Mike, I can share some of the things that we've written about that even during the pandemic. We've made a partnership and done some investments with Morehouse, with the Satcher Institute, to lift up more equity data, and we're doing the same thing with vaccinations. And we partner often with the CDC Foundation because they're a really great vehicle for us, because we're not going to know the frontline relationships as well. I think the bigger issue here is a societal issue about the digital poverty, and the importance of us recognizing and appreciating that not everybody can do telehealth or has a smartphone to participate in digital contact tracing. We know these things, but now we have to solve for that. It's unconscionable that we would have to build tools on paper because we don't have access to everyone in all parts of the US and in all sociodemographic groups to digital tools, because it's the 21st century. So we've been trying in our ways to be helpful in that space, but I think for the country, we've got to acknowledge that you can't just patch the problem after the fact, but we're going to have to create a level playing field. And if you're going to do equity, it ain't level all the time, is it? You got to give a little higher ground to some folks.
Perfect, thank you. With so many questions we're not going to be able to get to, we're going to transition to the next portion of our agenda. But I do want to again thank you, and thanks to Dr. Shah for your remarks. What a great way to kick off our first ever TechXpo, and we're really pleased to have you both as part of the program. I just want to briefly remind folks that you can find a full agenda link in the chat, and you'll see what comes next at 3 p.m. Eastern through 4:45 Eastern are some blocks of breakouts, as well as the opportunity to visit with some of our sponsors and exhibitors in a virtual exhibit hall that you can pop into virtually. But we've got some great breakouts focusing on contact tracing and disease investigation, exposure notification, data visualization and data and surveillance, innovation and management and monitoring of patients and linking, again, that clinic to community connection, thinking about technology in the vaccination campaign, as well as a late breaker session that we just added called Moving from Paper to Digital, the Evolution of a Vaccine Credential, which will be, again, one of our breakouts. The breakouts are live sessions, some of which the content will be pre-recorded and played by our staff team, and then some of which will be live sessions, and there'll be live discussion at the end of each breakout block. So we'll have a short break until 3 p.m. Eastern, top of the hour, and then you'll have the option of selecting which breakout session you want to join. All of our breakouts will be recorded, so you can watch them afterwards if you weren't able to attend, and all will be available to everyone who registered for the next 30 days. So you can also share with friends and share the link so that you can get this information out to whomever you'd like to share it with. So with that, again, Karen, thanks. We really owe you a debt of gratitude for the foundational work you did with Public Health 3.0, your work at ONC. And we also have the opportunity to hear from your predecessor at ONC, maybe not predecessor, future successor. Nikki Tripathi is joining us for one of our closing sessions after our main closing plenary. So it's really exciting to have these bookends to our time together. And thank you all again for joining us and our ASTHO team for supporting this event. It continues until about 7 o'clock tonight Eastern time, with lots of opportunities to connect, network, chat, and learn. So thanks for joining us. Be sure to get into our breakout block right at 3 o'clock Eastern, top of the hour. And we look forward to seeing you over the next few hours virtually in our networking lounges, as well as our exhibit hall and in our sessions. Everybody take care, and thanks again for joining us.